Yep, I'm recording on my end as well.
No worries, easy. So yeah, welcome everyone to our last regular session of the year. I say regular because we're going to try and set up something in Swapback for you guys. So we'll probably put out a poll later today about like what format you want that to be. So do let us know like what you'd like us to focus on and what sort of format and that sort of thing. But we'll put that up later today. Have a look at the Facebook group and that'll come up. Same thing with the week 11 recording. That should be up later today. So keep your eyes on the Facebook group and we should be good. But yeah, for now, I'll hand it off to Daniel to kick us off.
Great, thanks. So we're going to have a look at our very first topic for the last session of this term. So it's veins and venous return, which is a very, very short topic, only about 3 or 4 slides. The content itself was quite simple. So we're just going to speed through it today. So when it comes to veins and venous return, we're only going to focus on 3 areas because that's the only stuff you have to really keep in mind. It's the first one we're going to talk about is the vein structure. So what is the structure of a vein, and focusing more on what is the relevance of the structure when it comes to venous return. Then we'll talk about venous return, why it's important in terms of cardiac output. And then we're going to look at how we can actually influence venous return by increasing it through multiple mechanisms. And we normally only look at 3 of them. So okay, I'm not sharing screen. Okay, let me just reshare screen then. All right, hopefully everyone can see that now. Perfect. Okay, so yeah, I was just saying that with veins and venous return, we're only going to be looking at 3 areas. So vein structure, venous return and cardiac output, and factors influencing venous return. So I've got a bit of an overview of that on the right-hand side, just from my notes that I made last year. But we're going to be going to that in a bit more detail in the next few slides. So we're going to start off first of all with vein structure. Now, when it comes to the veins, there's a lot of things you can say about the structure of a vein, but we're only going to focus on 3 important aspects of it. And we're going to be comparing that to an artery because that's the sort of point of comparison we want to make in terms of how venous return is different to arterial supply of tissue. So when it comes to the veins, as opposed to arteries, they have a much bigger lumen. So they have a bigger capacity to actually hold blood. And so they're actually called volume reservoirs for that reason. And because they've got a much bigger lumen, a lot of your blood is actually found in your venous system because it's just got a higher capacity to hold blood than the arterial system does. So it's called a volume reservoir for that reason. It can hold a lot of blood. And in comparison to an artery, it's also thinner walls, right? And the artery, if you remember, had thick walls in the first place because it was a pressure reservoir. Now, what that meant was those thick walls and those thick elastic walls allowed the artery to be able to continue the blood pressure on from the heart and push the blood from the heart to the tissue because the blood would push on the walls of the thick artery and then get pushed back forward, right? That was sort of the principle behind why we had thick artery walls. And so that's why arteries are thick, but then veins, because they're quite far from the flow of the heart, when you reach a vein, there's not going to be a lot of pressure pushing the blood forward. So then we don't really rely upon blood pressure anymore. We rely upon other mechanisms that we'll have a look at later on. So veins have thinner walls. And the last thing that's very important distinguishing veins is that unlike arteries, veins also have one-way valves, right? And the key idea here is that blood flowing through veins is quite slow and non-pulsatile. And so what that means is there's the chance that blood can actually backflow, especially in areas where it's fighting gravity. Like for example, when it's trying to get up your leg, it's very high chance that it might just fall right back down because of gravity. So it has to have these one-way valves in place to prevent it from just pooling up. And we'll look at potentially later on why it's bad for it to pool up. But there's 2 key areas why, there are 2 reasons why it's not good for blood to pool up. But the one thing is that if blood pools up, it can actually start to clot because stasis is the basis for everything like infection and all that kind of stuff. And the second thing is also that if the blood starts to pool up and it doesn't get to the heart can't pump out as much blood. And so you're going to have a problem with your cardiac output. So we're going to have a look at that as well. All right. So the key principles here again were from the structure is that the arteries are thick and elastic to push blood into tissue, whereas veins focus on being thin and floppy, but prioritizing having a larger volume to deliver more blood from tissue to the heart. All right, so when it comes to venous return, it's good for our body to have a larger venous return. And the reason is that if you can have a larger venous return, so more blood entering into your heart, it means that you can fill up the heart more during diastole. And so if you can fill up your heart more during diastole, your end diastolic volume is going to be greater. And if your end diastolic volume is greater, it means you can actually push out more blood through two key mechanisms, right? The first one is that you just have more volume. So because your end diastolic volume minus your end systolic volume is going to be your cardiac output, because that's bigger, right? That means it's going to be just volume-wise bigger as well. But more importantly, if you're just filling up your ventricles with more blood, the ventricles are going to expand more. And the Frank-Starling principle, which I think we might have gone through before, if you fill up the ventricles more and they expand more, the cardiomyocyte orientation changes, the sarcomere orientation changes. And so what that means is that it's able to contract with a greater force of contraction. And if that doesn't really make sense, I recommend going back into our previous slides and having a look at that concept of Frank-Starling, because it sort of explains why greater expansion allows for even greater contraction as well. So you're able to deliver that higher volume of blood. Yeah, so here is just a diagram showing that. And up next, we have how we can actually control venous return. So there are three mechanisms that we focus on. The first one is, I couldn't really find any good images online, so I just drew a very, very basic diagram there. But essentially, the principle is very simple. It's autonomic control. So you have autonomic nerve fibers. So that's your sympathetic nervous system in this case, firing. And well, in some parts at least, it's sympathetic nervous system firing. And what that does is it causes the smooth muscle cells around. And when they contract, they're going to constrict that vein. And well, the symbols over here are a bit of a, I don't know, a muddle there, but what they're showing here is like this, because of that constriction, you have a lower diameter, which is that first symbol. So a lower diameter. And then what that means is higher resistance in that area. And so you're going to have higher pressure just at that point compared to other areas, right? And why do we do that? Well, I think just intuitively it makes sense. If you squeeze at that area, you're going to push blood out from that area up to, wherever you want it to go, towards the heart, really. Right, so you squeeze in that area, it's going to push blood forwards towards the heart, and it's not going to go backwards because of the one-way valves. But also, in terms of the physiological reason why, you can think about it as you're creating a high pressure at that point, and everywhere else around it is low pressure areas. So what you're doing is you're making the blood go from a high pressure point to a low pressure point, a principle that you would have seen time and time again in biology. So that's autonomic control, smooth muscle cells contracting to produce this effect. Now, one thing you might remember before is that I said the veins were very thin, right? The walls are very thin. And what that means is the muscular layer actually as well, the muscular cells, the smooth muscle cells that normally surround arteries in large numbers are here, but in a very, very slow, small quantity. And so this mechanism here is actually very ineffective when it comes to changing venous return. It can only do it a little bit, but it's not entirely effective because of how few smooth muscle cells there are around veins. And so our second mechanism is relied upon much more, which is a skeletal muscle pump. And in this case, what happens is it sort of makes intuitive sense. Your skeletal muscles, when they contract, they do pretty much the same thing. But of course, because they're bigger and much more, I guess they can contract more forcefully, they're able to achieve it to a greater degree, right? And the thing with this skeletal muscle pump is that it's active when you're contracting your muscles, and then the muscle belly bulges, and then it puts that pressure on the vein. Now, let's say you're on a flight for a very, very long period of time, or you just had surgery, and you're suddenly bedbound for a long period of time. You're no longer going to be contracting your foot muscles, for example. And so your blood is not going to have that same effective venous return because you're not contracting your foot muscles and you're not pushing blood back up to your heart. And so what can happen is that if you're staying still for a long period of time, because this skeletal muscle pump is not very active, you can actually have blood building up in your legs and that stasis potentially causing clots to form. But we're not going to focus on that too much today. That'll be something you probably go over a lot more next year with your respiratory systems unit. Okay, the last mechanism is the respiratory pump. The respiratory pump is probably the one that is hardest to understand. So I've got this diagram here, which hopefully clears things up. So I think we'll start off, I know it's got inhalation here on the left and exhalation on the right. I'm going to start off the opposite way. So we're going to look at exhalation first. So exhalation, you breathe out. Think about what happens to the size of your chest, right? You breathe out, your chest sort of decreases in size, right? Yep, so your chest decreases in size. And so as a result, you can think about your chest as a sort of a closed cavity. not the lungs part, but everything around it is a closed cavity. And so when you're decreasing the size of that cavity, you're going to increase the pressure of that cavity, which is kind of counterintuitive because you might think if you're breathing out air, the pressure in your chest might go down. But in the space around the lungs, the pressure actually goes up. So the interthoracic pressure goes up. And also, what's happening is, if you remember, the key idea is that when you're breathing out, your diaphragm is relaxing to be able to actually achieve that motion of breathing out. So when your diaphragm relaxes, it's going to sort of tilt upwards, and that's going to temporarily expand the abdominal space. So it's going to give it more space to sort of move its contents around, and there's going to be decreased intra-abdominal pressure. Okay, so the key idea there is increased interthoracic pressure and decreased intra-abdominal pressure. Now, why is that important? Well, if you remember, to be able for the principle here was that blood flows from a higher pressure area to a lower pressure area. And in this case, we're not really having that happening. So it's not going to really do much here. But then when you inhale, the opposite happens, right? You inhale, your chest expands and your diaphragm pushes down and your abdomen becomes squeezed because the diaphragm is pushing the abdominal contents below. So your thoracic pressure is going to be lower and your abdominal pressure will be higher. So that means your blood is now having a pressure gradient that it can use to move from the abdominal area up to the thoracic area. And that's how your blood is able to fight gravity, at least in that section of your body, and reach your heart. Okay, so that's the respiratory pump there. And that's pretty much it when it comes to all those topics. So if you can increase the venous return from these three mechanisms, it also means if you go back, you can increase the cardiac output, which can be useful in the context of exercise and other activities where you have a high metabolic demand and you need to achieve a high cardiac output. And one thing we didn't cover today, which you probably will cover at a later stage, is the consequences of not having high venous return, which I think you'll cover next year as being sort of deep vein thrombosis and blood clots. But I'll leave it there and pass it on to the next topic.
Thanks, Janal, sorry. I think, yeah. Can you guys see this thing? Okay, cool. So we're going to talk about the vascular endothelium. So what that is really just the layers surrounding the blood vessels and how sort of some of that it can release substances that cause vasoconstriction and vasodilation. So starting us off, there's let me get my laser pointer. So there's orienting yourself to the diagram on the right, we have three main layers: the tunica intima, the tunica media, and the tunica adventitia. And you can kind of see it here as well. So the key part of the tunica intima is just the simple squamous endothelium on the surface. This is what I guess the contents of the lumen comes into contact with. Underneath it is an extracellular matrix. A basement membrane also exists underneath it. And in between the tunica intima and the media, you have the internal elastic lamina. So after that, in the tunica media, we have the smooth muscle cells. Now, these are going to be very important when we talk about vasoconstriction, vasodilation. But continuing on, you have an external elastic lamina as well, as long as, alongside a tunica adventitia, which contains collagen and vasorum. Not sure if that's how you say it, but essentially those are small little blood vessels on the surface of these larger blood vessels, because we still need sort of nutrients to supply these endothelium cells and all this stuff in our actual blood vessel layers. So what I want to actually talk about is the internal elastic lamina. In between the intima and the media, it has holes. So this allows for the endothelium to communicate with the smooth muscle underneath. So our endothelium is going to release a bunch of different substances. The first thing we're going to talk about is nitric oxide. So if we looking at this diagram here, this green thing is really just the endothelium, and the red thing is the vascular smooth muscle. And in between is obviously going to be the internal elastic lamina, which has holes in it. So it allows for nitric oxide, which is secreted by the endothelial cells, to interact with the vascular smooth muscle. We call nitric oxide an endothelial derived because it's from the endothelium, releasing, relaxation factor. Should be releasing factor, but it's essentially causes relaxation of the vascular smooth muscle. We've got a bunch of different substances that can stimulate the formation of nitric oxide and other substances from the endothelium. So these are endothelium dependent vasodilators because they interact on the endothelium itself. So these you can kind of think of like on the outside, you have these stuff which acts on the endothelium, and then the endothelium produces this nitric oxide, which produces relaxation. Not only do you have a bunch of substances, we also have shear stress. So when a lot of blood flow passes through the endothelial cell, it's going to cause mechanical stress on the cells. And that it kind of makes sense that because of that, if we release nitric oxide, that would consequently reduce the pressure on the endothelial cells because the vessel is going to dilate. So nitric oxide in particular has a bunch of different functions. So we know that we talked about the relaxation part, but it has antithrombotic, anti-inflammatory, anti-apoptotic, and anti-proliferative mechanisms. We don't really need to know exactly how it all happens, but just know that nitric oxide does. Okay, so, well, how do we create nitric oxide? I talked about how there's a bunch of different substances that can cause the production of nitric oxide, such as acetylcholine and substance P. Essentially, that signaling on the endothelial cell causes an increase in calcium, and which promotes nitric oxide synthase enzyme action. Now, there's a bunch of different types of nitric oxide synthase found in different cells, but since we're talking about the endothelial cell, it's going to be synthase. And as you can see here, from L-arginine, we're going to go to L-citrulline and produce nitric oxide. On the diagram on the bottom, we can see sodium nitroprusside and glycerol trinitrate, which are two sort of analogs that we can use clinically that will mimic the actions of nitric oxide. I think it like releases nitric oxide here. I'm not sure exactly how it works, but point is we can put these things in which has the same effect. At the same effect being the activation of soluble guanylyl cyclase, SCG, which produces cyclic GMP. And this cyclic GMP causes an ultimate decrease in calcium, which causes smooth muscle relaxation, because we know that calcium is required for smooth muscle contraction or just muscle contraction in general. So a decrease of that makes sense for it to cause relaxation. So yeah, here's how all this is created. I talked about analogs for nitric oxide as a pharmacological agent, and equally, it's not really an analog, but it's an L-arginine derivative, which we can use that prevents nitric oxide from being produced properly. So that's L-NMMA or L-NAME, which inhibits this entire thing. Okay, so nitric oxide is a vasodilator, but we know that there are a lot of other vasodilators that act at, smooth muscles. So nitric oxide, prostacyclin, and endothelial-derived hyperpolarizing factor are the three main ones that we want to think about. So I haven't really introduced these two, but prostacyclin, you can see it in the COX pathway. Just like skipping forward a couple slides, this diagram kind of shows it here. So we have arachidonic acid, COX-1 to PGI2, which is prostacyclin. So in between nitric and prostacyclin, where it acts on the smooth muscle is pretty important and tells us a little bit about the lipid solubility. So I know that nitric oxide is going to go into the cell and act at this SCG, SGC. So it's going to be lipid soluble since it acts at a receptor inside the cytoplasm. It has a very short half-life, which actually makes it pretty useful for acute attacks. So we typically see it used in vasospastic angina, which I mentioned last week. Prostacyclin, non-lipid soluble, so it acts as a receptor on the surface of the smooth muscle. So if you can't really see that here, but yeah. One more thing is that it inhibits platelet aggregation as well by inhibiting, by prostacyclin's action. Okay, the third one, which is a little bit elusive, people don't really know exactly what it is, but we know that it exists, and it is the endothelin-derived hyperpolarizing factor. So basically, by blocking nitric oxide and PGI2 production, we still see a lot of vasodilation, especially at the smaller vessels deep in tissue. And that points to something like a EDHF existing. We know that, again, it's prominent in smaller vessels deep in tissue. We also know that it causes smooth muscle hyperpolarization through some ion transfer. We don't actually know the mechanism through which how it does this exactly. So there are a couple of theories proposed, and you'll go into a tiny bit of depth in your lectures. And ultimately, point is it causes vasodilation. Okay, so we talked about endothelial-derived relaxation and constricting factors. And really, in our body, we really just have a balance of these two things, which have a bunch of different effects. So it's kind of, it's not exactly saying the whole picture when it says relaxing factor, because it does a bunch of other stuff. It does, like I said, anti-thrombotic, anti-inflammatory, and anti-proliferative effects. Equally, the EDCF has the opposite effect. So if you're thinking about anti-thrombotic, it promotes thrombosis and promotes inflammation, vasoconstriction, vascular remodeling. We talked about nitric oxide, prostacyclin, and EDHF. And the sort of examples for EDCF is endothelin, angiotensin, and thromboxane A2. In particular, we're going to talk about endothelin a little bit. So orienting ourselves in this kind of diagram here, we can kind of see what we talked about with nitric oxide here, with endothelial-derived nitric oxide synthase. And you can kind of see how nitric oxide inhibits ECE here. Now, ECE is endothelin converting enzyme, which essentially causes the maturation of endothelin 1 for it to have effector action at the smooth muscle cells. So endothelin 1, there's like endothelin 1, 2, 3, 4, but we're really thinking about endothelin 1, and we're thinking about its action on ETA receptors. So when it activates these receptors, it causes long-lasting vasoconstriction. It potentiates and sort of has an additive effect on other constricting effects as well, and stimulates proliferation. And we can kind of, you can kind of see how blocking ETA receptors through ETA receptor antagonists can be used to cause relaxation. So it's used in pulmonary hypertension. And that's the end of that. Any questions in chat? And I'll hand it over to the next person.
All right, can people see that? Too easy. All right, thanks for that, Deepak. Okay, so this part is map regulation. Can I grab a pointer out? All right, never mind. So first of all, what is it? Mean arterial pressure is the average arterial pressure throughout one cardiac cycle, and it can be calculated using the equation of cardiac output times the total peripheral resistance, or if you're in an exam and they give you just the diastolic and systolic pressures, it's just the diastolic pressure minus 1/3 of the systolic pressure minus the diastolic pressure. And factors that affect the map arterial pressure or the mean arterial pressure can be given by the equation CO times TPR, as we look at factors that affect the cardiac output and the total peripheral resistance. In terms of the cardiac output, we know that it is created from stroke volume times heart rate. So any factors that affect stroke volume and heart rate will result in a change in the mean arterial pressure. So things such as preload, which is controlled by venous compliance, so how much blood goes back into the heart, and then also the amount of blood there is present, which is then determined on things such as the renal filtration and how, if there's more water in your plasma or your blood, then you're going to have more preload, and then you're going to be able to have a larger stroke volume, which means greater cardiac output, and so on and so forth, resulting in a greater mean arterial pressure. Sweet. Although there's a lot of factors that affect this, such as vascular anatomy, whether or not the vessels are constricted or not, if there's any damage to it, you, as year ones anyway, we only need to focus on two main ways that mean arterial pressure is regulated. And the first one is our baroreceptor reflex. And this is a very short-term and fast-acting response. So in long-term conditions, this is basically irrelevant. In terms of baroreceptors, they're basically stretch receptors found in the carotid sinus or the aortic arch. And basically what they do is detect whether there's an increase in blood pressure. And this is because our brain isn't very good at having local vasoconstrictors to prevent there being too much pressure, and it might blow out some of the neurons or damage the brain in any way due to like a hemorrhage or something. And basically to prevent that, we have these receptors that when mean arterial pressure increases, we get increased baroreceptor firing. And then this results in an increased parasympathetic drive or tone. And as we know, the parasympathetics is the rest and digest. So it drops your heart rates. And in doing so, that decreases your mean arterial pressure, as that decreases the second part of CO times your cardiac output, which is SV times HR. And basically by doing so, you decrease it. And basically that's why in clinical skills, you're often told not to palpate for the carotid pulse on both sides at the same time, because that pressing down will increase the baroreceptor firing rapidly, and that will cause parasympathetic your parasympathetic tone to increase rapidly, causing your heart rate to drop. And that's why you sometimes have patients that faint because you've pressed on their carotid sinus. And basically, yeah, it's used to protect the brain. All right, and then the next one is our long-term control of blood pressure. So the previous one, that's like seconds to minutes, and that's just a control for if there's just a sudden increase and it's trying to prevent the brain from like exploding basically. And the long-term control of blood pressure is determined by the RAS system, or the renin angiotensin aldosterone system, and it's comprised of three parts, and it's basically in the name. You got your renin, your angiotensin, and aldosterone. Our renin is basically made in our kidneys, and it's basically a molecule that is released by these special cells known as juxtaglomerular cells. And basically what they do is they detect a change in pressure or amount of blood, blood pressure. And basically they release this, which then converts angiotensinogen to angiotensin 1. And then angiotensin 1 is then converted into angiotensin 2. And if we look at this diagram to the right, it has a myriad of effects. So it causes vasoconstriction, increases sympathetic drive, enhances the thirst and ADH secretion, aldosterone secretion. And basically all these factors act to try and increase the blood volume. If there is a sudden a long-term decrease, and this is in terms of months and years or days to years. And then basically aldosterone works in the nephrons, or basically the filtration unit of your kidneys, and that increases the amount of water that is retained through increasing the amount of salt that's retained. And by doing so, this can increase your blood pressure if there is a marked drop. And basically, our body is very good at doing this. And basically, usually if you have a lot of excess salt or your blood pressure goes up a lot, your kidneys are very good at stabilizing this and returning it to the equilibrium point, which is the normal point. And during elevated pressures, the kidneys will act by increasing its kidney output. So it gets rid of more water if the blood pressure is too high, because it's just trying to remove more of it, and it will prevent water from leaving the body, or it will absorb more water back into the bloodstream. So the pressure will increase because you get more volume. And however, in terms of hypertension, because of the increased pressure for sustained periods of time, you get damage to these nephrons and these receptors within your kidneys that basically shift towards a higher elevation. And it basically creates the change that the new normal is set at a higher pressure. And that's why the patient always experiences having high blood pressure, as opposed to it coming back to the normal range that we state as normal, as the cells have been damaged or have had a shift and being desensitized and being pushed up higher. Sweet. And here's a quick summary slide. And basically it's to showcase that baroreceptors fire, then you have your CNS response in terms of your increased parasympathetic tone versus decreased sympathetic, as well as there's a few little factors as well, such as like fluid shift, and like that's just the shifting of fluids between cells to try and balance it out, as well as your aldosterone. But just remember, it's just the baroreceptor and renin system that you guys need to know. And I think that's the end of me. Awesome.
Yep, I think that's then my bit of content, which is lipid lowering drugs. So I'll go ahead and share screen and we'll get started. And this time I'll actually share screen. All right, there it is. So we're gonna have a look today at lipid lowering drugs. And this is another bit of pharmacology content. So we're gonna try and keep it high yield and focus on the important stuff. But just for your own knowledge, I've added everything in that your faculty covers. And so we'll just go over everything, but I'll focus and sort of emphasize the important bits more. All right, so topics covered in this slide kind of include atherosclerosis. So we will touch on it a little bit, but it's pretty much just going to be relying upon having had a look at James's PowerPoint from before. Like I think it was a couple of weeks ago, he made a really nice presentation explaining why how it occurs and why it's bad. So I recommend having a look at that the first few couple of slides, because they're only going to be the important ones we're going to be focusing on today. And then we're going to be having a look at, okay, it's a problem, but how are we going to actually deal with it in terms of pharmacology? And again, on the right there, I've got a bit of a summary that I made, I think last year when it came to this topic. And there's a lot of stuff there, but we're going to focus only on the important ones. So we're going to have a look at statins, fibrates, cholesterol absorption inhibitors. Those are probably the only important ones you have to really know about. But then you also probably will learn about some other agents like niacin, or I think vitamin B3 and fish oil, as well as PCSK9 inhibitors. And we're going to talk about what they are as well and what they do, because they're sort of the nucleus in the block as they've been described in your lectures. And so we're going to look at how they actually act on lowering your cholesterol, your blood cholesterol. Then we're going to have a look at, or we're not actually going to have a look, but we're going to talk about fibrinolytics, anticoagulants, and antiplatelets. They're not covered here. And the reason is that they're sort of covered more in depth in coming years when you learn about the coagulation pathway. All you have to know for that last bit of content is fibrinolytics are drugs that can rapidly break down a blood clot. And so they're only used in acute settings, usually for life-threatening blood clots. And that's there up in the image on the right, but also I've put it down in the comment, the speaker notes as well. So you can just know that that's the important part you have to take away from there. Okay, so probably the important part to be covering is a bit about cholesterol metabolism. So how does your body deal with cholesterol, right? The first thing that I want you to keep in mind when it comes to cholesterol metabolism is that when it comes to dealing with cholesterol, our goal is to obviously reduce cholesterol, but it's not to reduce it overall, because we still want some cholesterol to be able to do important things like, build your cell membranes. But to reduce cholesterol that's floating around in the blood, in the form of LDL, right? Because if you remember, cholesterol is not going to be floating around by itself. It's a lipid-based substance, and so it has to be bound to something. And in the case of the blood, it can be found in the form of LDL. And you want to really remove that because that's a really high cholesterol content protein. You want to get rid of that and prevent it from depositing in the vessel walls, where it can then cause atherosclerosis and obstruction of blood vessels and eventually ischemia of tissue. So the key points here is that there's multiple ways that cholesterol is metabolized in your body. The first way that we can deal with cholesterol is we can use it to synthesize bile. So if you look up here on the diagram, let's see if I can go back. So in the diagram, you can see that cholesterol is normally just stored in the liver, but it can be dealt with in several ways. The first primary way is that it can be used in the form of bile to break down other fats. So cholesterol used to make bile to break down other fats. The second thing that your body can do is also transport it around the body from the liver through things like VLDL, right? So I think that's very low density lipoproteins. And as the triacylglycerols, so the triglycerides inside the VLDL begin to be used up by your body, then this apolipoprotein becomes more and more dense. So it goes from a VLDL to an IDL or intermediate density, then LDL and HDL. So from very low up to high, right? And that's because you're taking away the cholesterol content and then the protein dominates. And so it becomes more dense, which is kind of counterintuitive. That's sort of how it works. You have the protein dominating as a result of the cholesterol being taken away and the fatty acids being taken away. And then the remnants, so whatever's left over after your body has taken away the triacylglycerols, they're taken back up by the liver. So the key idea here is that your liver sends out cholesterol to your body. Your body uses, not cholesterol, your liver sends out cholesterol, triacylglycerols, and other lipid products to your body. Your body uses some of them and then it's sent back up to the liver for reuptake. That's all you have to really keep in mind. Okay, so when it comes to why that's important, the key principle we want to keep in mind here is that if we act to lower the LDL in our body's physiology actually works in our favor. Because if we're going to lower LDL in our body, then LDL becomes kind of a scarce thing in our body. So your body tries to maximize the reuptake of that LDL so that it can really store it and look after it rather than just like let it go loose in the bloodstream and potentially just be used up by other parts of your body. So that's why whenever we lower LDL in the body, we're actually going to increase the reuptake of LDL by the liver. So it's going to have more receptors on it to take up LDL. And therefore, we're going to actually work to further reduce LDL in our bloodstream. It's a bit of a confusing concept. So I've just put that down there as a key principle. And we're going to be going over that a bit later as well. But if you're still a bit confused, have a look at the notes in the bottom of this slide, and it'll make more sense. So the last point I want to touch on over here is that we're going to actually lower cholesterol in the blood through two mechanisms. One, we can actually increase reuptake by the liver. So if your liver is taking up more of those HDL, LDL, IDL apolipoproteins, it's going to be able to then take up more cholesterol with it. Second thing we can do is increase the removal from the body. So what that means is, we said before that cholesterol is used to make bile. If we're removing that bile, right, from our gut through our feces, it means that we're going to get rid of cholesterol through that mechanism. The third thing we can do is decrease absorption of cholesterol from our diet in the first place. So we're going to decrease absorption from dietary fat. And all that's, again, in the speaker notes. So have a look at that. All right, so next up, we have our very first class of drugs that's going to be able to help us achieve a lowering of cholesterol, right, in our bloodstream. So I've got a diagram there explaining it. It's a bit complex, so I've also made a simpler one. And the main idea here is that, first of all, they're called statins, right? When you have a look at the drug name, the great thing about it is that all these drugs end in the word statin. So you kind of know straight away that it's going to be a statin based on that sort of ending there, right? Now, the important part is that when it comes to these three drugs, you actually taught all three of them, but I'd say focus only on the last one there, atorvastatin, because that's your, it's a drug on your drug list on e-pharmacology. So you really want to focus on that one more, but it's easy enough to remember all of them because they have the same common ending. So when it comes to the mechanism of action, the way that these statins work is that they act as enzyme inhibitors. And specifically, they act on an enzyme called HMG-CoA reductase, and they competitively inhibit that, and they act in the liver. So that's a lot of terminology there. But the main idea is that by inhibiting that enzyme, they prevent acetyl-CoA from actually becoming cholesterol, right? So you're actually decreasing cholesterol synthesis in the liver. So because you're inhibiting that enzyme, you can't make as much cholesterol in the liver, and therefore your hepatocytes essentially become starved of cholesterol. And so they'll respond by increasing their LDL receptors because your liver wants to get more cholesterol. So it's going to try and take it up from the blood if it can't make it itself. And so if you increase LDL receptors, you're going to have more LDL reuptake. So sure, you're going to end up with more LDL moving into your liver, but the important idea here is that they're moving away from your blood into the liver. So your blood is cleared of the LDL, and you're left with less LDL in the blood, which is what is our primary goal, to reduce that and then therefore achieve a lower risk of atherosclerosis. Okay? Now, in terms of indications, there's only really two areas we focus on statins with. The primary prevention is when it comes to high risk of cardiovascular disease. So when someone hasn't had a cardiac event, but they're at risk of a cardiac event, we might use this. For example, if they've already got very high profile lipid profiles and they're at risk of a cardiovascular disease, we might actually implement this to lower those lipid profiles and prevent that from occurring. The other use, though, is, let's say someone's already had a cardiac event like a STEMI. You can actually use it as a secondary prevention after that event has occurred to prevent another event like that occurring. Okay, so that's the sort of two main areas that we use statins in. And I haven't got any experience, unfortunately, on the wards, but from what I've heard, they actually use very, very frequently with patients. So side effects for this drug is that they're quite mild, but they're sort of typical, drug stuff like GI disturbance, insomnia, rash. There's a small diabetes risk and irreversible memory loss, which are kind of rare, but I wouldn't get too hung up on those two. Just know that it's actually quite well tolerated. It's got a very good side effect profile. Okay, now we come to fibrates. So you learn about, again, two fibrates when it comes to this area, gemfibrozil and fenofibrate. So they're technically both taught, but only one of them is on your core drug list. So I'd only focus really more on that one, like just really memorizing that drug as your typical drug in that class. And in terms of the mechanism of action, it is, again, another sort of inhibitor, but it inhibits, or not an inhibitor, sorry, it's agonist in this case. So it's actually enhancing the function of something, and it inhibits this weird protein called PFAR alpha. I'm not sure exactly what that stands for in full form. I'm sure you can have a look at that online. But the key idea here is that before, if we had a look, right, if you had a look before, HMG-CoA reductase, that was more so acting in the liver. So you were trying to alter the liver's metabolism of cholesterol, right? Over here, we're doing something different. We're now doing this in the periphery, in the muscle and adipose tissue. So keep that in mind, right? By agonizing PFAR alpha, we're actually going to increase something called lipoprotein lipase. And the good thing is, in this case, the name actually makes a lot more sense. Lipoprotein lipase is going to be a enzyme that breaks down lipoproteins. So things like LDL, it will break it down, and VLDL, it will break it down, primarily VLDL. So what's going to happen is this enzyme will digest VLDL that's found in your plasma, okay? So it'll digest it, and whenever it's digested, it's also going to take up and use the triglycerides inside of it, and hence it's got a secondary function of being also able to decrease triglycerides in your bloodstream. Now, another consequence is that, and again, it's not directly explained, but this fibrate also has the ability, separate ability, to be able to reduce the hepatic production of VLDL. I'm not too sure why, but it does have the ability to reduce that VLDL production in your liver cells. So it's kind of a different method altogether, but it does that. And so what's happening now is you're using up VLDL a lot in your bloodstream by your tissue, and you're also not producing as much VLDL in your liver. So again, your liver is in this problem where it's starved of cholesterol because it's got a lot less VLDL. And so it's going to try and take up more of the LDL from your bloodstream. And that's your primary goal, which is to reduce LDL in your bloodstream, right? So that's why it's got a therapeutic effect there. But notice that we emphasize this important point here, that it's also going to be working in your peripheries to metabolize triglycerides. So it has the effect of lowering triglycerides effectively, as well as lowering LDL levels. That's why it's also used when it comes to hypertriglyceridemia and mixed hyperlipidemia, where you have increased lipid profiles across the board. And side effects when it comes to this drug, common, so the GI disturbance, and you want to avoid then liver disease. I'm not sure if they go into this in your slides, but I had a bit of a look online, and the reason is it actually causes gallstones and hepatitis potentially as well because of the action that it has on the liver. But yeah, so here on the right again is just a bit of an explanation of that with a very poorly drawn diagram, but I hope that sort of makes sense. Okay, so next we come up to the third, probably the third of the important classes you want to cover. This is cholesterol absorption inhibitors. So thankfully, these drugs are named very aptly in terms of the function. So cholesterol absorption inhibitors inhibit the absorption of cholesterol from your diet, right? So you're going to consume cholesterol in your diet, but these drugs are going to prevent it from entering your bloodstream and becoming LDL and those sorts of things. So we talk about two main classes when it comes to this: the bile acid binding resins and the cholesterol uptake inhibitors. Now, bile acid binding resins again are named quite well, but there's two examples of them: cholestyramine and cholestyramine. Neither of them are on your core drug list, so I wouldn't get too hung up about them, but I just remember them as a class and what they do as a class. So as a class, they're bile acid binding. So they bind with bile acids. And if you bind these drugs with bile acids, then that bile acid becomes less functional because it's bound to by something. And so that means that those bile acids can't then break down dietary fat. And so you have less dietary fat absorption. Okay. And you also have the effect of less bile recycling because those bile acids have been bound to, they no longer can be endocytosed and recycled again because the structure has changed. And so you can't really do that anymore. And so the net effect, right, is that you have less functional bile and you can't take it up again. So all that bile is just lost through your GIT. You just, it comes out through your feces. And so what that means is your liver is going to try and deal with that low levels of bile in your body by trying to pump out more and more and more bile, right? And again, if you're going to produce bile, you use cholesterol to produce bile. So you're going to decrease cholesterol in your liver. And so we have this very wonderful effect of, again, reducing cholesterol overall, and therefore reducing LDL in the long term as well. So it's used for hypercholesterolemia and mixed hyperlipidemia as well. Side effects include GI disturbance. Now, because we said that it's going to prevent fat from being absorbed, think about consuming a high-fat diet, but they're not actually having that diet digested at all, like the fat content of it. So all that fat content remains. And so if you have that fat malabsorption, it can actually cause bloating and discomfort because you're not digesting it, and it's going to be staying in your feces as undigested fat. And yeah, those are sort of the key ideas there. And again, a bit of a poorly drawn diagram on the right there explaining what that does. Now we come to an important drug, important because it's on your core drug list. It's called ezetimibe. And in this case, it's probably it's what I would say is a true cholesterol uptake inhibitor. The previous one wasn't really inhibiting cholesterol uptake. It was sort of working through bile to prevent cholesterol being reabsorbed in the form of bile and just taken out in the form of feces. This one is a true cholesterol uptake inhibitor because it specifically prevents cholesterol being absorbed from your diet in the small intestines. And in the small intestines, the transport protein that allows cholesterol to enter into your brush border. What it does is it will inhibit that and therefore inhibit specifically cholesterol absorption from your intestinal brush border. Why is that important, right? Well, the key idea here is that it'll stop cholesterol being absorbed, but other fats can still be absorbed. So you can have fat-soluble vitamins like your KADE vitamins still being absorbed, which is important, right? Because you don't want to have vitamin deficiencies while you're on a drug. So that's why it's actually better tolerated than the other drugs on the previous slide, because it can actually still allow you to absorb the other fats and the fat-soluble vitamins. Okay, so because you're not absorbing cholesterol from your diet, your body will try and increase bile production. And the reason is it thinks there is a problem with fat breakdown. So it'll try and make more bile. And in doing so, it'll actually decrease the cholesterol that it has in its stores. And therefore, you have the same effect of lowering overall LDL. And indications wise, it's not, I've not seen it being described as a single therapy, a monotherapy. I've normally seen it being used online, at least as in conjunction with statins. So it actually helps improve the cardiovascular disease outcomes with statins by further lowering LDL that statins already lower. Side effects wise, it's actually better tolerated than bile acid binding resins because I said before, it can actually still allow for the absorption of fat-soluble vitamins and therefore not cause problems that we saw before of like bloating and abdominal discomfort because the fat is still being digested, only the cholesterol isn't. Okay, now there's other agents here as well. And again, I have not put too much for them because they're not too high yield, but I'll just put them here just for your own knowledge. So the first one is niacin or vitamin B3. Now, if you want to think about how you can remember that, the way that I sort of remembered it was that niacin has 3 syllables in it. And so you can remember it as vitamin B3. Just remember the B. I don't know how you'll remember that, but I just remembered it as vitamin B3. And the way that it works is it actually lowers VLDL secretion from the liver. Again, the mechanism is actually poorly understood, but it also reduces what's called LP9A. Now, don't be mistaken, it's just another name for a type of LDL. So it's actually working to reduce LDL here, which is the whole point of these lipid-lowering drugs. Fish oil. So fish oil is also, there's some evidence that it actually decreases cardiovascular disease risk, specifically tied with the omega-3 polyunsaturated fatty acids. They've potentially been linked with lowering triglycerides, although I think the clinical evidence on that is a bit, I guess, debatable. But yeah, that's sort of another thing you want to keep in mind. The last one is the new stuff, the new therapeutic novel agents. They're called PCSK9 inhibitors. And I think I've put somewhere in the notes as well what they stand for. It stands for pro-protein convertase subtilisin/kexin type 9 inhibitor. So a lot of a very big word there, but they're sort of abbreviated to PCSK9. And all you have to know is that it's pretty much this PCSK9 protein is a protease. So it's an enzyme that breaks down other proteins, right? And it's circulating in the bloodstream. And the way that it works is that PCSK9, this protease, is actually able to enhance the lysosomal degradation of LDL receptors. So in simple terms, PCSK9 is able to degrade and get rid of LDL receptors. And if that happens, you're going to have less LDL reuptake, which is a bad thing, right? So we inhibit this so that we have less LDL receptor degradation and more of it is kept up in your liver cell membranes. And so your liver cell takes up more LDL. I think there's a bit of a typo there, but that's sort of what I was trying to go for. And again, these are not as high yield. Just put them there for your own reference. Just have a look at them, and you don't memorize like side effects or anything for that because they don't actually go through that with you in your lectures. All you have to do is know briefly that they do exist and that they do have some potential therapeutic function. So summary wise, this is a diagram here that I think comes straight from your lectures, but they just sort of summarize the key drugs and where they act. And I recommend just going through and seeing if you can reason and understand why these drugs have been placed where they are. I hope that all made sense, and thanks for sticking around for that last bit of farm content. And feel free to let me know in the chat if you have other questions. Otherwise, I'll pass it on to our next topic.
Unfortunately, not the last bit of farm content. We've still got antiarrhythmics, which I'm going to be going through. So let me just share my screen. Now, this is a little bit of a tricky topic, especially for me. Like when I read this through the first time, it was very, very challenging just wrapping my head around the different drug classes and how they sort of work. In order to make this a bit more interesting, because it can get a little bit boring, if you can find any place in my slides where I've spelled arrhythmia wrong, then you don't have to sit your exams or something similar. Because I definitely will have made a mistake. It's very, very difficult to spell. But anyways, I'm going to go into all the different drug classes. Let me know if there's any questions that you have, because you'll see a lot of these drugs pop up in different areas of your sort of learning. So you might see random things like anesthetics come up in here. So anesthesia, local anesthesia drugs, and you might be confused as to why does it cause sort of benefits in arrhythmia. And we'll get into that in a couple of slides time. So again, let me know if you have any questions in the chat. So first of all, just defining what arrhythmias are. And you may have sort of heard of this in your clinical skills. You may have heard of it in other places. It is basically just abnormal heart rhythms. And usually the problem is associated with the conduction system. So you've got some issue with the way that your action potentials are firing. Maybe your SA nodes, AV nodes are not working very well, or those specialized nerve fibers are just not up to standard. There can be other reasons. So it might be like damage to the muscle tissue itself, which then indirectly causes damage to the conduction system. But for the most part, either the primary, secondary, or tertiary reason is going to be that conduction system failing. Now, there are a couple of different categories. And for the most part, you can either differentiate them based on the effect that they have or the location that arrhythmia is located in. So in terms of the effect, you can either consider it to be a bradyarrhythmia, tachyarrhythmia. So in other words, does the arrhythmia cause your heart rate to go down and then be irregular? which is bradyarrhythmia, or does it increase your heart rate and then also cause arrhythmia? Most of the time it's tachyarrhythmia, but you can have some of the other type. The more important classification is where it's located. So supraventricular arrhythmia, I'm not sure why they didn't just call it atrial arrhythmia. Supraventricular just means above the ventricles, which is the atria. So in effect, your fibrillations or your arrhythmia is starting within the tissue of the atrium. Now you can have some common ones that you might have heard of. So atrial fibrillation. You can also have supraventricular tachycardia. That is just, again, the atria firing way too fast, which can predispose to arrhythmias because there's no coordination happening. You can also have paroxysmal supraventricular tachycardia, or PVT, or it can be also paroxysmal supraventricular tachyarrhythmia. And this is kind of the same thing as the one above, but this time it just happens sort of more sporadically. So one second you might be fine, and then in a couple of minutes time, you just have this abnormal heart rhythm and palpitations. So those are the three main types. And then ventricular ones, these are a little bit easier. So they start in the ventricles, generally more common. You get ectopics, so just beats happening out of nowhere. And we're going to cover a lot of these in ECG interpretation at the end, so stick around for that. You've got tachycardia, so just, again, increased heart rate, and then ventricular fibrillation. So ventricular fibrillation and atrial fibrillation, they're very, very good ones to just know about, where your tissue is just kind of contracting without coordination. And generally, atrial fibrillation is the more common one, and it's associated with high mortality rates. If anyone knows about why atrial fibrillation is associated with high mortality rates, feel free to chuck it in the chat. It's just a good thing to know. I think we'll cover it in some pathologies later on. But if someone knows why it can be quite lethal, and someone else in our team can check that out. All right, so that's a brief overview of arrhythmia. What is the pathophysiology? Well, there are, again, two major reasons, and I kind of covered one, being that your pacemaker nodes are kind of firing either spontaneously or inappropriately. So your AV node, your SA node, they just kind of got a life of their own. So for example, if the SA node suddenly decides to beat at 120 instead of 100, you can get some form of arrhythmia. If the SA node suddenly stops working and the AV node takes over, that can cause arrhythmia. If the AV node to beat faster, that can cause arrhythmia. So any problem in the pacemaker cells can cause arrhythmias. The next common one, which I think your lecturer goes into a bit more detail with, is problems with conduction. So this is where, remember, we talked about the heart conduction system, and we talked about it starting at the SA node, going through to the AV node, then going through the Purkinje fibers, and so on. So we kind of discussed that before. There's a lot more complexity there. But for our purposes, there are sort of three main ways that conduction system can fail. The first one is you have a heart block. Again, you may have gone over this with ECGs. We will go over it again at the end of today's session. But you have some sort of blockage in the AV node, and there are kind of categories that classify these in terms of severity. So you might have something that's kind of slightly damaged, and in that case, maybe everything's still able to pump sort of semi-properly, but you might get some paroxysmal arrhythmias. And then other times the AV node is completely blocked. And so now the atria and the ventricles are completely separate from each other in terms of firing pattern. Re-entry circuits are a bit more difficult to conceptualize. And again, you don't need to know this in a huge amount of detail. But I've put a diagram up here on the top right, just to show you, and I might get a pointer up just to kind of annotate this a bit. So up here is kind of a diagram of what that looks like. And if you imagine this is sort of a heart tissue, and for some reason it sort of diverges into sort of two circuits, and you can imagine this being sort of coming out of the AV node, going into the Purkinje fibers that are going to the left and the right ventricles. That's sort of what this might show. And what happens is that this is a normal situation where things are kind of happening symmetrically almost. Whereas over here, you've got some sort of damaged tissue. And again, think about sort of predisposing factors like ischemia and heart attacks that can cause this. What happens is that, and it can get a bit confusing, but what's really happening is as the current is going down, because that tissue is damaged, it's not able to actually conduct anything while it's going down. And similarly, as it goes down here, maybe it's not able to conduct it back up. So this is not really that problematic. But what can happen is as the current goes down, it won't be able to go through, but as it goes around, the tissue has already gotten past its refractory period. So it's already kind of cooled off, and it might be able to conduct a little bit back up. So in other words, as it's going down, it can't do anything, or it can't conduct, but as it goes up, eventually it's cooled off and it's able to kind of go back up. What this is problematic is that this current can now go up, re-enter back into the circuit, and then keep going around and around and around like this. So in other words, if you've done like physics or anything, this is like a short circuit where your neurons are just going to be firing repeatedly without any real purpose, which can lead to arrhythmias. And generally it's to do with an obstacle like ischemic tissue. After depolarizations occurs when, and there's sort of like two types, there's delayed versions and there's early ones, but you don't need to know the difference. The main thing is that you have a depolarization that's happening later on, which is interrupting the previous depolarization that has already happened, which can then sort of build up as a sort of domino effect and lead to more problems in the future. What can lead to arrhythmias? There's a lot of factors, and you'll go over this many, many times as you go through your course, but you can have electrolyte imbalances, so hyperkalemia, hypokalemia leading to arrhythmias, catecholamines, so you've got your adrenaline and things like that. If you have too much adrenaline, you might feel this during a couple of hours before an exam, when you've got adrenaline running around your body and suddenly your heart starts to palpitate really, really fast. But in some diseases, you can have too many catecholamines, which can actually lead to arrhythmias. Ischemia or MI, we already talked about. Cardiac surgery, if you've damaged some of the conduction system. Anatomical abnormalities, which we'll go over in ECGs, and then hypoxia or chronic hypoxia can also lead to arrhythmias. So let's actually get into the drug classes. Now, there are generally 4 classes of drugs that we like to use, and they are classified according to the, I'm going to butcher this, so if someone knows the actual pronunciation, please help me. The Vaughan-William or Vago, I don't know, whatever. It's VW classification. And there are 4 major drug categories: class 1, class 2, class 3, class 4. Now, the numbers don't help because each of them is actually a separate drug category altogether, or they have at least a different mode of action. And you've already seen a lot of these. So you've seen sodium channel blockers, you've seen beta channel blockers, you've seen potassium and calcium channel blockers, but they've just been repurposed, or at least have sort of secondary functions that are useful in slowing down arrhythmias. So in effect, each drug class is specifically blocking one type of receptor that's involved in generating this action potential, which we went over in physiology. So this is your either your ventricular or your myocyte action potential. Now, the way I like to remember it, because I couldn't really visualize this in my head, is that I would just remember the phrase NAB key card. I'm not sure where I got that from. I think I just made it up, but it kind of helped me to pinpoint which specific receptor is responsible for which phase. So in other words, if you're looking at phase 1, or at least, sorry, class 1, not phase 1. If you're looking at the class 1 drugs, they're going to be the sodium, Na. Class 2 is going to be beta channel blockers. Class 3 will be the potassium, and then class 4 is calcium. Hope that helps. If not, there's always other mnemonics to use, or you don't need to use mnemonics at all. But there we go. Now let's go into each of the classes. I think generally class 1 antiarrhythmics are a little bit more high yield, and I'll explain what these random pictures are on the right in just a sec. I think they're a bit more high yield because they actually contain 3 subclasses. So they might be able to ask you a couple more questions about this. And each of these classes has its own set of modes of actions as well as some adverse effects. So with class 1, we said they're sodium channel blockers, but they all act in different ways on the action potential duration. So class 1A is going to lengthen action potential duration, and it's generally given for things like ventricular atrial arrhythmias. Again, why are we lengthening it? Because we want to delay how long the action potential takes, because clearly it's going too fast. With class 1B, this is the one that confused me a little bit. Again, I remember telling you guys that there's going to be a lot of overlap with other things that we've done so far. And remember back to nociception or like pain medications, we talked about local anesthetics. So one of the side effects, or one of the added effects, I guess, of local anesthetics, like lignocaine, is that it acts as a sodium channel blocker, or at least it acts as an antiarrhythmic. What this does is it shortens AP duration, which sounds a bit weird, and I'll get to that in just a sec. It's also given it's given IV for ventricular arrhythmia post AMI, again, to reduce your risk of future arrhythmias. And then finally, class 1C, such as flecainide. I don't think a lot of these are actually core drugs, so you don't need to remember the name specifically. Maybe just remember lignocaine because you've seen that before. There's no change to AP duration, and it's the strongest of them all. Again, it seems a bit counterintuitive because it's not really causing any change in the AP. Again, I'll get to that. It is the drug of choice for supraventricular tachycardia, or at least it's one of the drugs used in that situation. Now, some of the adverse effects are also sort of important to know. With class 1A, you can get this condition or a change in your ECG known as Torsades de Pointe or something like that. It's in French, I think. And you may have seen that in the slides. I think the lecturer might show you that kind of looks like a bunch of like really fast ECG traces, and they're happening really frequently. And that predisposes you to developing more arrhythmias, and it can be quite lethal. So class 1A drugs, while they are used for arrhythmias, they can also cause arrhythmic or pro-arrhythmic ECG changes. You can also get chronic lupus-like symptoms, which again, you don't need to know how that happens. With class 1B, I think it's predictable to say that they have some local anesthesia just because of the other modes of action. That's not necessarily too bad though. And class 1C is notorious for some types of cardiotoxicity, so keep that in mind. Now, I said I'll explain the pictures on the side. Again, this is just a way that I like to remember how these medications are ordered. I remembered, it's kind of weird. I remembered the phrase like salty cab driver. So salt being obviously sodium, and then cab, so CAB, in other words, class C, class A, class B, it kind of orders it in terms of their modes of action and also kind of their strengths. So class C being the strongest one, so that comes first. Class A is this, I guess, the second strongest. It lengthens the AP duration. And then class B is generally the weakest. And again, I told you the fact that it shortens AP duration isn't that helpful, but it does have a little bit of effect. It's just not the one that's most prescribed. Okay, so that's the way I remembered it. If that helps, again, feel free to use it. Okay, class 2. So these are your beta channel blockers. You've seen this before, but now they're being repurposed for arrhythmias. So generally, we're trying to block the beta 1 adrenergic receptors. So these are the ones found on the heart tissue. And what this is going to do is it's going to have a couple of effects. The major thing is that the beta 1 receptors are found not only on the muscle tissue, but also on the nodal tissue. So the AV node, the SA node. What this will do is it's going to block the receptor. Now your adrenaline cannot actually bind to the heart tissue, or at least the nodal tissue, and therefore the nodal tissue is not going to be able to fire as quickly. So that's good for arrhythmias where they're firing too fast. And you can sort of see on the graph, I've included all the graphs on the side, which you can have a look at for interest. The decreased depolarization slope, so this bit here where it's sort of starting off, it takes a lot longer, and therefore each of these beats happens a lot less frequently. So it's going to reduce your overall heart rate, which again is beneficial. So it's used for things like atrial fibrillation, that really dangerous one we talked about, post-myocardial infarct, and also to improve stable heart failure. One thing to keep in mind is that I believe beta channel blockers are good in the long term for stable heart failure, but in the short term, they can aggravate or exaggerate heart failure, because in effect, what you're doing is reducing the contractility of your heart tissue. You're giving a beta blocker, right? So in the short term, you might get worsening effects, which is why you want to be really careful with making sure you titrate it or give a very small amount as you go, and then gradually build up when it seems more safe. There are some drugs like atenolol, which I think are on your core drug list. If not, that's okay. Just remember the ol suffix, meaning beta blockers. So you should be able to remember that. Atenolol is generally cardioselective, whereas some other examples like propranolol are not. So they can have some more adverse effects outside of the cardiac tissue. Generally, though, it doesn't matter if it's cardioselective or not. Most of these will have adverse effects. And one of the major ones you want to keep in mind is going to be bronchoconstriction. So we discussed the fact that if you have a beta blocker, you do not want to give it to anyone who has asthma or has evidence of asthma or like COPD or anything like that, because they already have a very restricted airway. If you give them beta blockers, even though that's the purpose of it is to target the heart tissue, it's inevitably going to go to the lungs and the airways, constrict them, and lead to worsening of symptoms and potentially hypoxia and death. So you do not want to prescribe those. Class 3 is your potassium channel blockers. Again, we've seen these many times. This time we're blocking the voltage-gated potassium channels, which is going to reduce the efflux of potassium. Why is this good? Well, remember that potassium is one of the major ions that will hyperpolarize my neuron. Or like we're talking about neurons, but we're also talking about your specialized nodal tissues, which are effectively neurons. If those potassium come in, it's going to hyperpolarize my cells and my neurons, which means they're not going to be able to fire as frequently. If I keep that potassium inside, rather than letting them escape and then giving the neurons a chance to fire again, that means it's going to have even less chance of it being able to fire again. So this is going to be, again, good for your arrhythmias. Keeps all your cells like super, super quiescent. So it prolongs AP duration in cardiomyocytes. Again, you can sort of see that here, the curve is kind of dilating off a little bit at the end. And it therefore is going to increase your QT interval. You don't need to know the specifics about ECG changes. It's more about the drug names and things like that. So indications, really good for ventricular fibrillation, and it can be used for other ones as well. There are two kind of drugs that you should be aware about. Sotalol. So this is it's a beta blocker technically, but it also has class 3 effects. If you're having trouble like kind of differentiating between beta blockers and beta agonists, actually I'll go over that probably a little bit later in the chat. It's probably not important for now. So sotalol, beta blocker, has class 3 effects. Amiodarone is kind of like it just does everything basically. So it not only is a potassium channel blocker, it's a sodium channel blocker, it's a calcium channel blocker, and it acts pretty much almost everywhere in the heart. So the atria, the ventricles, sometimes even the nodes. However, with this last one, amiodarone, be really careful because it has a lot of serious side effects. So while it seems like it's a really good medication, because of the fact that it has such a broad MOA, it's going to have some thyroid, lung, liver toxicity. So you want to look out for those in patients who are on it. And then pro-arrhythmic effects as well. So remember that torsade points I was talking about. So this can actually lead to this. So a lot of things you'll notice, common patterns. Antiarrhythmics can cause arrhythmias, some of them. So you want to be really careful with the dose that you're giving, as well as monitoring them for any adverse effects. Now, finally, we've got our class 4 medication, so calcium channel blockers. This one's a bit more intuitive. We know that calcium is required for contractions to happen in our heart tissues. So if we block these channels, not as much calcium is going to be able to bind, so less contractions. Specifically, we can talk about the nodal tissues, so the AV nodes, the SA nodes. If I slow down the depolarization that's happening within these nodes, and I think the lecturer talks specifically about the AV node, but I think it is effective in most of the nodes. It might be a bit more selective for AV nodes. It suppresses the abnormal automaticity that you see in arrhythmias. So the classic one that you'll discuss is verapamil. So we've discussed calcium channel blockers before, and you know that there's some that are cardioselective, some that are more selective towards the peripheries. So obviously in this case, we're going to try and focus on ones that are going to be more cardioselective. So these are going to be the non-dihydropyridine calcium channel blockers, generally given orally, so can be quite fast acting, acute relief for atrial fibrillation, as well as prevention. So these drugs can be used to prevent future events from happening. However, be very careful when you're considering giving verapamil specifically with beta blockers. And the reason why is verapamil is already blocking stuff. It's blocking tissues in the heart. So it's already slowing down contractility. If you give beta blockers on top of that, it's going to not only further decrease contractility, it's going to also further decrease nodal conduction. So you might actually end up with a situation where you are inducing heart failure in a patient who is on these medications. So in effect, you've got arrhythmia over here, where your heart is acting too fast. You give verapamil, which is slowing it down to normal, but then you give beta blockers again, which is slowing it down so much that it leads to heart failure, which you don't want. So be careful with some of the combinations that are being used. There are some unclassified medications. So these don't come under the VW classification. And the reason why is because they have slightly different modes of actions. You don't need to know about these too much, except for like one or two things which I'll highlight, which can be good for exams and sometimes like sort of buzzwords pop up. With digoxin, again, you'll come across this many times. It is like, it sounds really good. So it blocks AV nodal conduction, slows ventricular rate in atrial fibrillation. Its mode of action is a bit strange. I'd encourage you to just have a look at the diagram. It's to do with, again, ion inflow and outflow from the cardiac myocytes, but it's sort of an indirect pathway that it takes rather than being super direct. It is a bit like it's still being researched, so you don't need to know it too much. The main thing is that some of these effects can also be due to some central vagal stimulation, so stimulating the vagus nerve, slowing down the heart rate. However, high doses, so generally low doses are okay, but high doses of digoxin, wherever they're used, can cause ventricular arrhythmias. And I know I've said this for a lot of these medications, but for digoxin, it's particularly so. So, digoxin sounds amazing, but if you go a little bit too high, you can actually cause even fatal ventricular arrhythmias in patients. So you want to be super careful. Adenosine is kind of a buzzwordy one. It's given IV. It is the major drug of choice for SVTs, so supraventricular tachyarrhythmias or tachycardias. Because of the way that its mode of action works, it hyperpolarizes conducting tissues, slows pacemaking, and because of this, and because it's given IV, it's able to really, really quickly convert your heart rate back into a sinus rhythm. So if anyone asks you in an exam, what medication is prescribed for someone with SVT, as long as they don't have contraindications, which, as from what I'm aware, adenosine doesn't have any that we need to be mindful of. Correct me if I'm wrong, but I believe adenosine is just the first one you go for. Okay, so that's the main medications. I've gone over the 4 drug classes. There are different modes of actions. In terms of just bringing it all back together, the main things you just want to know are that sort of those mnemonics to remember which drug class corresponds to which channel blocker. Maybe some of the adverse effects of your class 1 medications. Potentially just think back to the drug combinations that you want to try and avoid. And then finally know that digoxin is good, but in high doses it's bad. Adenosine is the drug of choice for SVT, and it's given IV. And those are sort of the main takeaway points that I would really focus on for this section. And that's it. I'll pass it on to clinical reasoning.
Perfect. Thank you, Janam. So, so clinical reasoning is basically the way I've decided to do this is to give you guys sort of a constellation of presentations. So the idea is I'm going to give you through a whole bunch of different sort of symptoms and patterns of presentation that you're likely to encounter or may encounter for different conditions. So the idea is if you are in a Monski or eventually in an actual patient interview and you are suspecting cardiovascular injury or disease, then you can start using these to sort of narrow things down. And so whereas in previous sessions we've gone through like history and examination just as their own things on their own, I want to try and link them more clearly to the actual conditions. That's the general idea. So this doesn't have every condition on it. I've focused only on the more high yield stuff. So this is not an exhaustive list. I've put a bunch of common risk factors there. So each of these conditions has its own risk factors. And some of them are more unique than others. I've made a note of that where I can. But there are some general risk factors that we find pretty commonly across cardiovascular disease. So hypertension and diabetes are really big ones. Obesity is another big one. Hypercholesterolemia for some disorders, smoking, and relevant family history. When I say relevant family history, that can be either for cardiovascular disorders in general or for that condition in particular. So especially if you have someone who has a family history of that condition, then that's going to be a significant risk factor for them having the condition as well. Okay, so the first one, AMI, heart attack. You guys have all heard of it. So we probably know by now that it's because you have a block in the coronary arteries, and then you start getting death of cardiac muscle cells, basically. So your major symptom for this is chest pain. Before it, you might have angina, fatigue, or shortness of breath, and then the rest of those symptoms might be there. Probably the other major one would be the pale or clammy skin. Keep in mind a couple of things. So first of all, that the critical thing with this is the acute presentation. So this is generally not going to happen over a long period of time. And that also can present quite differently in people. So the pattern of pain can be different. Sometimes it's just chest pain. It can be different parts of the chest. It can be parts of the arm. So you shouldn't rule something in or out because it doesn't fit the stereotypical presentation necessarily. So our gold standard investigation for an AMI is cardiac troponin. So that particular marker is quite specific to MIs. We can also look at things like creatine kinase, and I think to a degree C-reactive protein, but those aren't quite as specific for AMIs. And when we go through ECG, you'll be able to see how we can use the ECG to actually figure out where in the heart the AMI has happened. So which tissue is affected. All right. So heart failure is another term. So AMIs refer to damage to the heart. Heart failure is sort of an end state. It's sort of, we're at the point where the heart, for whatever reason, is not working as well as it should be. So it could be that the muscle is dead or not working for whatever reason. It could be that there's too much blood, there's too high pressure in either the pulmonary or the systemic circulation, which prevents the pump from being able to work as effectively. Because as you guys probably know by now, the heart is not pushing blood through the body, right? It's actually just a machine to change the pressure of the various chambers. And it's the pressure differential that actually drives movement of blood through your body. Okay, so if the pressure differential is messed up because we have hypertension in the systemic circulation, for example, then your left ventricle has to either work much harder or it will just not work as well. And you can have stenosis of the valves, either of the semilunar valves or the larger valves between the atrium and atria and ventricles. Okay, so the presentation for this one is quite different between the left and right-sided heart failure. So this should be a really central thing for you guys to understand the differences between them. And you can totally understand why there are differences if you think about what's actually happening. So in right-sided heart failure, we're failing to pump blood from the right atrium, which is coming from your venous circulation, into the pulmonary circulation. Okay, so the outcome for that is going to be that you have a backup of blood in your venous system and in your periphery. So your jugular vein is going to be is going to have increased pressure because it usually empties into the right atrium, but the right atrium isn't accepting as much blood as usual because the right ventricle is backed up because we've got right-sided heart failure. Same thing with pitting and peripheral edema. So pitting edema is like when you press on it, it doesn't immediately rebound. It takes some time to come back. Peripheral is just stuff like ankle swelling, wrist swelling, that sort of stuff. So not in the central body. And those are the same thing. So it's because we have too much blood around the body, which isn't getting pumped through the body like normal, that blood then contributes to edema. The other ones, in all of these slides, I've bolded the really critical symptoms. The other stuff is still important, so don't ignore it. But the bolded stuff is the really important stuff. So left-sided, on the other hand, instead of having a backup of fluid in your systemic circulation, you have a backup of fluid in your lungs. So you can have difficulty breathing because your lungs are not designed to have that much blood in them. It's usually going to be worse. So paroxysmal nocturnal, my goodness, and orthopnea, so lying down, you have trouble breathing. That's because both, well, the nocturnal thing is mostly just because you lie down to sleep. But the idea is in that position, your normal return of your veins is inhibited. So you're not as good at bringing blood back to your heart. And so if your heart is not working well enough in the first place, that can just exacerbate that. And you can also get lung crackle. So that's on examination when you're auscultating. Yeah, so the right-sided heart failure does not usually, it doesn't always happen on its own. It's more likely that it happens with left-sided heart failure than on its own, like in isolation, whereas left-sided heart failure is more likely to happen by itself. And you can kind of understand why that happens, because once you have left-sided heart failure, you have a backup in the pulmonary circulation, and that is easier. It's easier to back up from the pulmonary circulation to the right ventricle than from the systemic circulation to the left ventricle, just because there's more space in the systemic circulation, so there's more give there. Whereas in the right, the right ventricle and the pulmonary circulation, there's less sort of give or slack in the system. Yep. So chest X-rays and ECGs are good investigations for these. All right. I think the investigation thing I forgot to change here for that, so I'll correct that in the slides when I actually put them up. Sorry, after this. So aortic stenosis, this is specifically for the aortic valve. You can also have pulmonary stenosis, and it has different symptoms because we're backing up into a different place, but it has the same sort of general mechanism, which is you have fibrosis or calcification of the valve, which makes it too stiff. So that's bad because it can't close as well as it usually does, and it also can't open as well as it usually does. So when it's meant to be closed, we get backflow, and when it's meant to be open, we don't get as much front flow as we should. So that's quite bad. One of the really big giveaways for this one is dyspnea on exertion. So if they give you a cardio like CIP, it'll probably involve somebody like trying to climb flights of stairs or something and they get shortness of breath. That's a pretty good sign of aortic stenosis. You'll get usually also, when I say angina there, I think I'm using the wrong term. It should just be retrosternal chest pain because of the location of the aortic valve. But that's the general idea. So because we are not able to get blood through our body as much as we would like to, or as much as we need, then all your muscles are not getting as much oxygen as they need. And so you get shortness of breath, trouble breathing, and then sort of weakness. Okay. Coarctation of the aorta. This one is generally congenital disease. So usually it'll happen, we have the arch of the aorta and it gives off a brachiocephalic trunks. And then if you reach the sort of start of the descending aorta, when it starts to go down, that's usually where we have a narrowing. And that is what contributes to our major symptom for this one, which is sign, actually, not symptom, which is radiofemoral delay. Okay, so when you take their pulse on their wrist and on their femur, you will feel the pulse first on the wrist and then on the femur, because there's a delay because of that constriction, right? So that is, I can't think really of many other major symptoms, many other major diseases which involve radiofemoral delay. So that's a pretty good sign to say that coarctation of the aorta is a problem. And you often have it present fairly young, especially if it's a congenital one. There's also an adult pattern, but you don't need to know as much about that. So often the patients for this will be like some 8-year-old gets brought in by their parent. And you'll get left ventricular hypertrophy. So that's basically like your left ventricle is trying to pump against this narrowing, which is not good, and makes it work harder. And when it works harder, as with other stuff, so you also get this with aortic valve stenosis sometimes, the muscle will just grow bigger and bigger. And that'll show up on various scans that you can do as your both the fact that your muscle is getting bigger, which is trying to help the heart pump harder. The side effect of that is that your left ventricle then has lowered volume, which means that your cardiac output can actually be reduced, which is not good. Okay, atrial fibrillation. So we just talked about some of the drugs that get rid of this. The actual cause, as you guys will know by now, is our cardiac conduction system. Usually it's very ordered. In this case, there's something wrong. The major symptom of this is palpitation. So again, your history, you'll ask the patient, or the STEM will talk about asking the patient about feeling the heart racing at random points. And that's the major thing that'll tell you about this one. Again, when we go through ECG, that'll be a really clear way of showing you how AF shows up in ECGs. Okay, pericarditis. So you guys know about the pericardium. We have different layers there, sort of sandwiched around the heart to protect it. And we can have multiple causes. So it can either be because of an infection, and usually when it's an infection, it's an acute presentation. So this happens fairly quickly because this person is like in the normal course of an infection. If you have a systemic cause, so it could be like kidney disease or something, then that can take longer. So that can be more sort of prolonged and result in a longer disease. So the major symptom of this one, major sign, I keep on confusing them, is a pericardial rub. So the key difference between a pericardial and pleural rub, which you guys actually probably don't need to know yet, but we'll need to know eventually, is a pericardial rub is when you get the patient to stop breathing. You will still hear on auscultation a sort of like friction or rubbing sound. So that's your examination. And when you hear that, you know that there's probably something causing that friction, which is frequently pericarditis. Okay, cardiac tamponade. This is sort of linked to pericarditis, so it is often found as a complication of pericarditis. So one of the big things is that when you auscultate, it'll be like, sounds underwater are frequently muffled, and there's no exception here. So because there's so much water between the heart and the pericardium, and then again, between that and the external surface of the body, where you would normally hear the heart sounds fairly clearly, they're now going to be much more muffled and difficult to discern. So that's a clue towards a sort of effusion of fluid between the pericardium and the heart. So the reason why this and pericarditis more broadly are bad is because they massively increase the pressure on the outside of the heart. So that's not good. The whole point of the heart is to expand and contract, expand and contract. If you inhibit that expansion by increasing the pressure on the heart, then that can severely prevent the heart from working effectively. So your cardiac output is again going to be reduced, which can have bad consequences for the rest of your body. Okay, infective endocarditis. So this one is one of the ones where like it really varies depending on the cause. So IV drug use is a major risk factor for this one. And usually when we see it in an IV drug user who's got infected by something because they used like an unhygienic needle or use drugs in an unhygienic place, usually they'll get it in the tricuspid valve, but it can happen on any valve. So any valve and any place. So like places in the atrium, especially where there's not much flow, which allows things to sort of take hold, and things, and just all 4 valves, so both the atrioventricular valves and both the semilunar valves have the potential to be infected. So like we both need usually for this disease to actually develop, we need the organism to be present. So there needs to be some sort of pathogen in the blood, and the endothelium usually needs to be already compromised in some way. So naturally your body wants to avoid getting its heart infected. And so there's usually a bunch of really robust defenses, one of which is that the endothelium doesn't allow bacteria and viruses to adhere easily. But if you have a defect in that and then you get a pathogen, then you can have a lot of problems. So a few things need to go wrong for it to happen. When we don't know what causes it, that should be staph A, by the way. The organism is often that. We can also look at things like strep viridans when we are looking at people who have dental procedures, because that's a major risk factor. And another major part that you guys should be aware of is that people with artificial heart parts can be at much increased risk of these because those heart parts don't have the natural body defenses against infection, right? Because they're just made of metal. Okay, so the major finding for this one on examination is splinter hemorrhages throughout the body. So this is the reason we look for those Osler's nodes and those Janeway lesions, especially when we're looking at a patient's hands or something, because they're a really good sign for infective endocarditis, and the other stuff there will also happen. So we usually do a blood culture for IE, but it may come back negative, and that doesn't necessarily mean that they don't have IE. Okay, so it can be caused by other stuff like fungi or certain bacteria which don't respond well to the culture. So you shouldn't rule out IE based on a negative blood culture, but you can rule in IE. I'll say that this patient does have IE if you get the right results from that. Okay, rheumatic fever. This one, it doesn't happen isn't not too common, but they do like throwing it in because it's important for public health, kind of. This one is like at much higher risk / more prevalent in Indigenous communities. And so the overall progression of the disease is basically you get a strep pyogenes infection. You have a normal immune response to that, but the antibodies produced for strep pyogenes then go on and they cross-react with tissues in the heart and other places in the body. And then we end up with things like joint pain, fever, weird heart sounds, and chorea. I don't know if that's chorea or chorea actually, but it's basically we have like jerky, weird, sort of pointless movements. So it's not that you're trying to do something, you're just a bit jerky. It's like you get really weird random stuff happening. Okie dokie. Thoracic outlet syndrome, this one's really quick. So we get a brachial plexus compression due to just sort of crowding often in the thoracic outlet right at the top of your rib cage. And we get pain and altered sensation in the affected arm, and particularly we'll get sensory impairment in the C8 and T1 dermatomes, if you remember those. So if you get altered sensation, it's not across the whole arm, it's only in those places, and that might be a suggestion that we've got a problem with the thoracic outlet. Okay, and the last little bit from me here. Two diseases at the top here, aortic dissection and abdominal aortic aneurysm. These are both very, very nasty because they're basically bad things happening to the most important blood vessel in your body, which hopefully you understand why that's potentially dangerous. So dissection is we have multiple layers of endothelium. So you guys will know by now we have all those different tunicas. And so they might separate, which allows blood to sort of get in between them and balloon out and be where it shouldn't be, basically. We like everything, in its normal layers. In aneurysm, so there's some sort of weakness, so often this can be caused by something like atherosclerosis or something similar. And so blood collects in that area and sort of bulges out. So either of them so either a dissection or a burst AAA, they can cause severe pain because obviously fainting, lowered blood pressure because you're losing blood, and tachycardia because your heart is trying to compensate. Your AAA is going to cause pain in your abdomen and back. And when you try and auscultate, you might be able to feel a much stronger abdominal pulse than normal because you've got this big sort of balloon of blood. And they're both very dangerous, especially in older patients. Finally, paroxysm of unknown origin, it's sort of just like we don't know what's going on. So we have a little bit of criteria for what you need to define it, but obviously we don't know what happened. So yeah, we don't know the pathophysiology because it doesn't have a pathophysiology by definition. So probably don't put that down as your answer. Like don't go to the examiner and be like, I think the patient has pyrexia of unknown origin. It's just sort of trivia almost. Right, so yeah, feel free to chuck your questions in chat if there's anything that is unclear that you'd like to know more about. For now, I'll hand back over to Jane Ann for ECG interpretation, I think.
Yes. Now, I am somewhat conscious of time, so I've asked people in the chat if there's sort of any specific part of ECG interpretation you wanted more support with, considering it's a pretty big topic, and I'm not sure if you've seen the slides, but I've split it up into 4 major parts just because of how much content there is. There are some sections which I would be okay with skipping. So like maybe part 1, where it talks about all the leads and traces and stuff like that. Maybe you're comfortable with that. I'll go over all of it anyways, but I'll try and focus. So I got a couple of people in the chat saying that you wanted a bit more support with like myocardial infarctions, how to sort of localize them, as well as I think like cardiac axis and stuff like that. And so basically a lot of the calculation based questions can be a bit tricky. So I'll try and focus on that a bit more, and I'll spend a little bit less time on these slides. And if there's anything more specific you want to talk about or you're kind of confused, please let me know in the chat. I've got it open, so I shouldn't miss anything. If I do, then someone please let me know. All right, so part 1 of this 4-part journey is leads and traces. So this is in a time, prehistoric times, where I used to actually be bothered drawing stuff. So you're going to get some nice pictures in the first couple of slides. We know what an ECG is. I'm not going to go over the definitions. Just the main thing on this slide is the types of leads that you'll get. So you've got 2 major types. You've got the limb leads, and you can call these chest leads, but fancy name is precordial. You've got 6 leads in each. And so in the limb leads, you've got the standard ones from 1 through to 3. In the augmented leads, you've got augmented VR, augmented VL, augmented VF. These are named kind of nicely because you know that these are actually telling you kind of exactly where they're placed on the body. We'll get to that in a sec. Precordial leads are very straightforward, V1 all the way through to V6. Now, the main sort of ideas to keep in mind for future are that the standard leads are all bipolar, so you require a positive and a negative. Whereas with the augmented leads and the precordial leads, there's obviously the 9 of them combined, but they're all unipolar. So they only need a positive lead. The other one is basically neutral or a ground lead. But we won't get into the physics of it all. So you've got limb leads, chest leads, and each lead, this is the main point, will view the heart from a different angle, which is why we have so many of them. This is our classic 12 lead system. So here is, again, diagram to show you what these leads look like and where they're placed. With the standard leads, you've got leads 1 through to 3, and this is just showing the orientation of all of them. Now, just a point I wanted to clarify, the arrows are a bit misleading. So the main thing I want you to keep in mind is that the positive lead is what you're viewing stuff from. So think about the positive lead as being the camera that's looking at the heart from a specific angle. And so these arrows are actually, like, technically should be flipped the other way. I'll give you a reason as to why these arrows are as they are. But think about sort of like, for example, with lead 2, this is a positive lead. So it's going to be looking at the heart from the bottom. Okay, so that's the main idea. Now, where are they placed? Technically, like usually they're placed on the wrists, so the right arm or right wrist, and the left leg or the right leg. I'm not sure if there's a reason why it's the left leg most of the time. I wouldn't really focus too much on the Einthoven triangle. Like I just drew it because it was in a lecture somewhere. It kind of gives you an idea about the angles that they're viewing it at. So generally with a lot of these, it's a bit counterintuitive. You are talking about angles. When you say plus 60, you're saying it's anti-clockwise from the left arm. So if you think about drawing a line across here and then going around like this, or maybe, yes, it's going around like this. Plus 60 would be sort of like 60 degrees down. It's a bit weird. I'll go over that in the next couple of slides. With the augmented leads, they've got an A in front of them, And again, the name nicely because they tell you where they are. So AVR would be the right arm, AVL left arm, AVF is going to be the foot. And the cool thing is that it doesn't require 2 leads. I said they're unipolar. So they only actually require the 1 lead, which is positive. And the second lead, or like the neutral bit, is actually just a combination or sort of midway between the other 2 leads that we've already set up in our previous standard leads. So again, a little bit of like physics and stuff. We don't need to go into that. But the main point is that it only requires 1 positive lead. Everything else is already set up from before. And again, the positive is where you're looking at it from, not in this direction of the arrow. That's that. The chest leads are a bit more straightforward. They are unipolar, so they're V1 through to V6. V1, like if you want to think about it really simply, V1 is sort of more in the midline, a little bit to the right, and then you go across to the left of the body until you get almost basically like underneath the armpit. And that would be sort of the location of V6. Now, there are specific places which you need to place them. So I've put some of the landmarks. I don't think you need to remember these. I don't think we ever got a question on it. I hope not. I hope you guys don't get a question on it because it's very, very low yield at this stage. But that's there for completion. You don't need to remember it for our purposes. Unipolar, I already mentioned. The main difference between these and the limb leads are that limb leads will look at everything from sort of like this plane. So if you think about coronal section where you're cutting your body in half, front and back, that is the way it's looking at the heart. So front and back. In the precordial leads, you can visualize this as being sort of transverse. So it's looking at it, if you were to slice the heart like this, that's sort of the view that you're getting of the heart with the transverse leads. Again, I said you don't need to memorize where they are. Just know that the ordering is from midline sort of in the right to more to the left progressively. All right, now basically you can chuck out everything I've talked about so far. If you really don't want to remember all that, that's fine. Just remember this slide. So the limb leads, remember this diagram so that you know sort of the angles that each of the leads are looking at. And I sort of hope that this tells you why I've drawn the arrows in the previous slides in the way that I did, in sort of the opposite direction to the positive lead. The reason why is because it's just generally in diagrams drawn like that. So you've got the heart in the middle, you've got your lead 1 going out like this, lead 2 going out like this, lead 3 going out like this, and then you've got the augmented leads going around sort of in almost a triangle separated by 360 divided by 3, so 120 degrees. And like the counterintuitive part is that it's actually looking at, like if you pick lead 2, for example, you're looking at the heart from lead 2, that positive lead, going up to the sort of bottom part of the heart. So the inferior part, maybe a bit of the anterior part, maybe a bit of the left part of the heart. So that's why we're kind of focusing on the orientation of the heart a lot in the previous sort of anatomy section, talked about the borders and things, because each of these is going to view a different border and a different sort of section of the heart tissue. And it's the positive electrode that's doing all the work. Here is just another view of those chest leads. Yeah, so those are the precordial and the standard and augmented. Now, just a quick word on the graphing paper. It's a good idea to know what all of this means. And if I was just to give you a brief summary, just remember that the y-axis, so the one going up and down vertical, is going to be voltage. So it's kind of, again, the physics is not important. It's just saying how strongly does this bit contract of the muscle, right? So that's the voltage. Across the horizontal axis, you've got time. That one's pretty intuitive. The small boxes and the large boxes have different meanings though. So with the small boxes, if you just think about small squares versus large squares, one small square is about 1 millimeter in length and width. But the main idea is that it's going to time for 0.04 seconds. So keep that in mind. That's the only number you need to remember really. And then you just think about one large square as being 5 by 5. So just multiply that number by 5 and it gives you the time. Hopefully that's straightforward. And then with the voltage, you can just think like 2 of these big boxes is going to give you 1 millivolt. So then one of these large, sorry, did I say small? No, 2 of these large boxes equals 1 millivolt. So that means one large square should be 0.5 millivolts. So just remember the 2 numbers, right? It's just that one small square is 0.04 seconds across, and it's one large square is going to be 0.5 millivolts in terms of vertical. Hopefully that wasn't too confusing. Now, what do these ECG traces actually mean? So we talked about in physiology, the P wave, QRS complex, T wave. What does it actually mean? Why do we even get waves in the first place? Whenever you get an upward wave, so things going up, you're thinking about depolarization towards the positive electrode. So where I'm looking at, my positive electrode is like the eye that's looking at the heart tissue from a particular angle. If the depolarization is coming towards me, to my eye, that's going to be an upward deflection. It sees that as being something coming towards it. If it's actually going the opposite direction though, and we'll get to why this is possible, then it's going to be a downward deflection. So it's going to go downwards. This does explain a little bit as to why the AVR, like in particular, is inverted. And the reason why is because if I go back, have a look at these leads, right? They're all sort of, maybe like AVL is a bit weird. But if you just look at most of these other leads, they're kind of pointing in the direction that the heart would be sending its electrical signals through. Remember that if I was to like draw the heart in here, do I have an annotate button? No, maybe not. Actually, I do. If I was to draw the heart, and this is going to be a really crappy diagram with my mouse, but if you think about the heart as being sort of like that shape, and the sort of electrical signal is going down like this, right? So in this sort of direction, which means that all of these leads are kind of pointing in the right direction, either sort of downwards or more to the left, whereas AVR is located on the complete opposite side. In fact, it's pretty much the complete opposite, right, of where the conduction is going, which is why when everything else looks positive, because stuff is going towards it, AVR will look negative. So hopefully that kind of clarifies any confusions anyone may have had. So that's why AVR can be a bit tricky. All right, let's get to part two, the more important part, which is the phases of the ECG cycle. Now I'll focus on the main part. So we talked about P, QRS, T, and physiology. Let's actually be a bit more specific in terms of what each of those means. So again, from a time when I could draw stuff unnecessarily, I just annotated each of the different parts on an ECG trace. So here's sort of a mock example of what a normal trace should look like. With the P wave, that's basically it. It's going to be the first little point at the start. It's the first major upward deflection at the start. Very, very small. So this represents atrial depolarization, and you can't really appreciate it that well here, but it's going to be asymmetrical in some ways. So generally the first half of the P wave is going to be where the right atrium contracts, and then the second half is where the left atrium contracts. And we may have talked about the fact that, the SA node is on the right atrium. It has to send some signals to the left atrium. I believe it's through Bachman's bundle. It has to send them through to the left atrium before it then goes down to the ventricles, through the Purkinje fibers and everything through the AV node. So that's why there's a kind of splitting. And you'll see some pathologies where the P wave looks nice and round here, but if it splits into two, maybe the first half is happening first, and then the second half is somehow being delayed, which it shouldn't be. The height and width should be less than 2.5 small squares, which in this case, you can't really tell. Again, it's not a perfect diagram, but it is. And it's generally always rounded, and it's positive except for in the AVR lead. So we know why that's the case already. With the PR interval, we're thinking about, okay, the start of the P wave to around about where the Q wave begins, I guess. Or yeah, around where the Q wave is, or at least where the R wave starts. So that's why it's called PR. So where the R wave starts, we're going to stop. Represents the time from atrial activation, so which was the P wave, to the start of ventricular activation, which is basically what the QRS complex is showing us. It normally should be about 3 to 5 small squares. And someone mentioned you wanted to talk a bit about AV blocks and stuff like that. This is where you'll see the pathology. So when the PR interval is longer or shorter or just like irregular and weird, that's where you have a problem with that sort of conduction. All right. QRS complex, really straightforward. It's ventricular depolarization. Why do we have 3 bits? Well, Q is for the septal part. So like the septum between the atria and the ventricles, or mostly the ventricles, is where the Q wave is showing. The R wave, the biggest one, is where the ventricles actually contract. So that's pushing out all the blood. And then the S wave is the Purkinje fibers. And why is the S wave going down? I encourage you to just think about the anatomy of where the Purkinje fibers are traveling. If anyone has an answer to that, like why is the S wave a downward deflection, chuck it in the chat and I'll have a look. Normally it should be about less than 3 small squares, and generally we measure it from the start of the Q wave to the end of the R wave. And I've drawn it a bit more broadly on this diagram here. The ST segment, this is again another pathology which we'll see with the myocardial infarcts. It should be isoelectric. In other words, it should be straight like this, and it should be sort of like, if you imagine the start bit here, which was at around like 0-ish or a relative 0, it should be around that position again. So the ST segment. If it's elevated or depressed, and it can be depressed as well, it can indicate potential myocardial infarct, which we'll get to later. T wave, that's the last little bit there. Ventricular repolarization. So we've already got atrial depolarization. We just did ventricular depolarization. Now we have the ventricles repolarizing, preparing for the next cycle. It should be asymmetrical a little bit. So the incline is generally less steep than the decline. That's not important for us to know though. And it's inverted wave in the AVR. So we talked about why that's the case. QT interval, again, not too important. It represents, so we think about the QRS complex being ventricular depolarization, T wave being repolarization. So it is just a combination of everything happening in the ventricles in that one cardiac cycle. So total ventricular activity should be around 0.33 to 0.42 seconds. And it generally, you don't want to measure this. You can just say half the distance or less than half the distance between consecutive R waves. All right, finally, U wave. I had to draw it in because it wasn't actually part of this diagram. And it's for a good reason, because it generally isn't seen. It represents a little bit of late Purkinje fiber repolarization, but it's very rarely seen. And it should, if it's there, be after the T wave, and it should follow the same direction around about. However, note that, for the previous one, so the QT interval and the U wave, because either they're not seen at all, or just because they're not very interesting in terms of pathology, I'm not going to include them in the analysis section. The main parts we're going to be looking at are going to be the other ones sort of before it. All right, I haven't got any questions. I've got a couple of questions. I might just go on a little bit just because of time. And then I'll come back to the questions a bit later. Okay, now the actual most important bit is the interpretation section. So I've got the list again, like I always do. So on the left-hand side, what the steps are that you should be taking. Generally, you want to start with details, then go to rate and rhythm, cardiac axis, ECG trace. I'll try and spend less time on these things though. So details and errors, obviously you want to take note of the name of the patient so you know it's the correct person. Avoids embarrassment in OSCEs if you have any time, so that you can see what progress was made since the last ECG trace was taken for that patient. And then technical errors, just make sure that the baseline is isoelectric, so it's a straight line. Calibration, if you saw at the beginning, you've got this calibration sort of bit there. It should be the 2 big squares high, and I think around a little bit less than 1, or it should be about 1 big square-ish. Where is it? Okay, there we go. Electrodes, just make sure they haven't been misplaced. So make sure that only AVR is inverted, everything else is still up. I think you go into an example of patients being either a cold temperature or they're feeling anxious, and because they're shaking, the electrodes look like they're shaking a lot, but it's actually just because they're moving around a little bit. So keep that in mind. Okay, rate and rhythm. These are just mathematical calculations, so I'm not going to spend too much time on it. If you have normocardia, that's just normal heart rate, 60 to 100. Tachycardia is greater than 100, so too fast. Bradycardia is too slow, it's less than 60. Again, this will vary based on individual patients, so less than 60 might not be that bad. Generally, we use a lead 2 because I haven't got a full ECG trace here, but if you look at lead 2, it's always at the bottom, and it goes for the longest for about 6 or 7 cycles. So you can really, really measure, especially if it's an irregular rhythm, you can measure it with lead 2. So regular rhythms, really straightforward. Look between 2 R waves. So we know the R wave is up here. If you just go from this location to the next R wave, measure that distance, you can either use the number of large squares or small squares to be able to calculate. So 300 divided by LS, so large squares, 1,500 divided by small squares. If it's an irregular rhythm, so there's not a consistent distance between R waves, then you can go for slightly longer sample size. So look at 6 R waves, in other words, 5 of those gaps, and then just multiply all of those numbers by 5. So 1,500 or 7,500. Hopefully that is straightforward. Rhythm. So if it's regular, we need to, and I've already talked about this with heart rate, as long as the intervals between the R waves are consistent, that's a quick measure of saying that this is a normal sinus rhythm. Some other points, you should always have 1 P wave in the cycle. Every P wave needs to be followed by a QRS complex, and you need to make sure these distances are sort of the widths of each of these waves that we talked about is normal. In effect, it should just look like a normal PQRS T wave, and R waves need to be consistent. Irregular means that the R waves seem to vary a little bit. If it's regularly irregular, still an overall pattern to it. So they might repeat at some points. Irregular is something to worry about. That's just where everything is random. And why we worried about it is it could indicate some sort of underlying lethal arrhythmias. Cardiac axis. So someone pointed out this as being one of the things you want to talk about. This is definitely one that is confusing. Just remember that the axis is supposed to represent the average direction that depolarization takes. So remember, we talked about the fact that it should be going a little bit to the left and downwards. If it's not, and it's like, for example, more concentrated on the left or more concentrated on the right, then it indicates there's some sort of issue. The main ones just to keep in mind are that if it's left deviation, then we could be having left ventricular hypertrophy, just because there's more muscle there. So the fibers or the electrical impulses tend to go more to the left, or we could have loss of electrical activity in the right ventricle. So everything's concentrated in the left. And basically everything is flipped over for right axis deviation. Here's again, a couple of diagrams for just the steps. The way you do this is first you look at the QRS complexes of 3 major leads, really 2 at the start and then the other one later. So I'll maybe go to this slide first. So you look at lead 1 and AVF and you think about the QRS complexes. Is it positive or is it negative? Positive means that the big R wave is taller than the S wave going down. Negative means that the R wave seems to be smaller than the S wave going down. So positive or negative. And then we use our knowledge of those diagrams I showed you before regarding which side of each of these leads is positive or negative. So remember, lead 1 points directly to the left. So the positive is on this side, the negative is on the opposite side. Lead 2 points downwards. So positive is on here, negative is on here. And AVF is just pointing straight down to the foot. So it's going to be positive down here, negative over here. If you remember these ones, then you'll be okay for these questions. And then basically what you do is just a fun game of figuring out where the overlaps are. So if you know lead 1 is positive, lead 2 is positive, then you know that, I'll go to the next slide so you can see a diagram, but you might know that that's potentially like normal. Lead 2 and lead AVF, if they're positive, there might be some sort of issue or something like that. You're just figuring out the overlaps. And here's what that looks like. So once you find the overlap region, you know that it's going to be either a left axis deviation, if it's more pointing to in the upper sort of, again, this is the patient's perspective. So for us, it's the upper right quadrant. For them, it's the upper left. Right axis deviation is down here. Extreme axis deviation is where it just goes completely in the opposite direction to normal. And then normal is going to be down here, where we want it to go, right? Down and left. So generally, as a practical point, you only use lead 1 and AVF to begin with, because it just gives you the right quadrant most of the time. The only problem can arise is if you localize it to this quadrant up here, because you've got a bit of chance that it's LAD, but you've also got a bit of chance that it's a normal axis. And just to clarify which one is which, you can bring in lead 2 because that'll specify it. And again, go back to the previous slide to sort of figure out why that's the case. All right. Again, I'll spend not too much time on these. So the ECG trace now, the P wave should be one wave. It should be sort of continuous. If it's not, we might get splitting of the wave. So if it's the right atrium that is hypertrophying, then you might get a very, very tall wave because that's where everything starts with the SA node. If it's the left atrium that's hypertrophying, then that can mean that you get a split wave because it takes longer to reach the left side as opposed to contracting the right side. And then mitral stenosis is, you kind of get a similar thing, but now you get wider and bifid P waves rather than just wider or bifid P waves. So my question to you is just if anyone's still remaining. I don't know if anyone's, yeah, there's still 10 people. Okay. If anyone wants to type in the chat, why do you think mitral stenosis gives similar symptoms or at least similar ECG trace in the P wave to left atrial hypertrophy? As a bit of a thinking point. Okay, now we come to the PR wave. This is the one I was talking about. So the AV node, remember the PR wave is the difference between, or it's the atrial contraction to the ventricular contraction. If we get it being shorter or longer, there's a problem with that signal reaching from the atria to the ventricles. What is getting those signals across? It's the AV node. So it should normally be 3 to 5 small squares in length. However, if it's less than 3, it's gone way too fast. And one condition which you might hear about in your lectures is the Wolff-Parkinson-White syndrome. Basically, you just have an accessory bundle that is bypassing the AV node. So it's managing to go past the AV node. Remember, the AV node tries to delay things a bit. If it's not able to, we've got some sort of accessory bundle in the way. If it's larger than 5 small squares, it's way too slow. And that is your classic AV block. And there are three major types. So we'll discuss the severities. The first one looks like this. It's your classic sort of the PR intervals being a little bit longer, but you'll see that, every P wave, you still have your QRS complex coming after. You got your sort of T wave happening later, and everything looks fine. It's just that everything is wider out. So this is your least severe first degree AV block. Then for the next slide, I'm going to focus on the secondary AV blocks. I put on the next slide because there's two types. So I'll go to that first. You've got your type 1 Mobitz AV, second degree AV block. That's where the PR interval may start out fine, but then later on it gets larger and larger and longer until eventually it just dies off, and then it starts again. So it gets longer and longer and longer and longer, stops, and then repeats through that cycle. And I'd encourage you to think about the physiology of why this might be the case, but that's for another sort of topic. With the type 2, we get PR intervals being regular, so they all look fine, but for some reason, eventually some QRS complexes start to disappear. Why is that happening? Again, think about the physiology. You've got so much of a blockage happening that potentially no signals are getting through to the ventricles where ventricular depolarization, i.e. the QRS complex, should be happening. So PR is fine, but QRS just seems to disappear in random spots. And then finally to the third degree AV block, this is just, it's crazy. It's where the AV node is gone completely. So the atria is going to contract, but it's not going to be able to send signals to the ventricles. So now the ventricles contract by themselves. So they each have different rates. And so you'll notice the atria is definitely going faster, because it's got that SA node, the natural sort of faster pacemaker. And the QRS complexes just happen, once, and then wait, and then it happens another time. Because the AV node, or the AV node's gone, the remaining nodes are a lot slower. Hopefully that makes sense. All right. Ventricular hypertrophy. I'm not going to
Jainam, I did have a question. What's the difference between, how can you actually tell second degree block and second degree type 2 and type 3? What is the actual defining difference?
So you're talking about second degree or like Mobitz type 2
Mobitz
versus
type 2 and third degree.
Yeah, really good question. So they look very similar. The only difference is that you can think about the ratio between the amount of QRS complexes you have versus the ratio of P waves that you have. So if you go back to here, you'll notice there's such a massive gap between where QRS complexes happen. And one way you can really quantify this is count the number of P waves in given number of cycles, count the number of QRS complexes. If you notice that the ratio is for QRS complexes versus P waves is really, really low, it's more likely to be a third degree block versus if the ratio is 3:1 or 5:1-ish, then that's going to be more of a second degree AV Mobitz type 2. Does that make sense?
Yep, very good. Thank you.
Yeah, no worries at all. It is a point of confusion, but just think about how many times QRS actually comes up. Now, LVH, I think this is a bit more straightforward, ventricular hypertrophy is a bit more straightforward. You're looking at the precordial lead, so the V1 through to V6. Remember what I said, V1, V2-ish is going to be at the front. And if you think about which ventricle is sort of facing more at the front, remember that it's going to be, I want you to think about this, I'll talk about it later. Is it going to be the left or the right ventricle? And then if you think about the ones more on the side, V5, V6, that's going to be pointing to another ventricle. That might help differentiate which ventricles might be enlarged versus which might not be. So in terms of QRS, we first look at the Q wave. If it's a lot deeper or wider than normal, this could indicate some sort of necrosis in the tissue, which is indicative of an old myocardial infarct. If we then think about ventricular hypertrophy, we're looking at which side or which precordial leads tend to receiving stronger signals because it's enlarged. If it's left ventricle, we know that the V1, V2 leads at the front are going to be closer to that left ventricle because of the way the heart is tilted. So if it's a bit of maths, I know it's really annoying, but you just want to be able to compare V1 and V2 to V5 and V6. If the greatest amplitude of the S wave, which is going, I think down, and then the R wave in V5, V6 is going up. If you can add them up, the greatest amplitudes, if it's greater than 7, it's going to be a left ventricular hypertrophy. And this is talking about large squares. Right ventricular hypertrophy is kind of the opposite, except now you're thinking about 2 large squares instead. For some reason, it has a lower number, or at least a lower threshold. And again, think back to the anatomy. And then finally, bundle branch blocks. So the bundle branches, remember what they're doing in terms of their anatomy. They're taking everything down to the ventricles, to the Purkinje fibers. So we're thinking about the R wave being where ventricular depolarization happens, that really big spike in the QRS complex. If it's a left bundle branch block, LBBB, we're going to get an M-shaped R wave. We're going to get a wider QRS complex in specifically leads V5 and V6, because that's where the left ventricle is. Sorry, this is, I think the V5, V6 is where the right ventricle is. And that makes sense because the left side is blocked. Sorry about that. And then the right bundle branch block, because the right side is blocked off, more stuff tends to go back to the left side, which is where V1 and V2 is. So hopefully that makes sense as well. Okay, finally, I'll try and be really quick with this. The ST segments are really important because they tell us if there's going to be a MI. This is probably the most high yield part, to be honest. Like the rest of the stuff is more just for your knowledge. You'll get more of these questions come up in your exam because they can ask you a lot of stuff about it. So N-STEMI is either way you have it.
And what's the actual definition of a bundle branch block?
So remember what the bundle branches are doing. If I remember my anatomy correctly, remember that it's the AV node, then you get the bundle branches left and right coming off, and then you get them going into the Purkinje fibers, which go into the ventricles, right? So bundle branch block will be where you have some sort of blockage in those fibers. And again, the reasons why that can happen are like variable. So you could have someone just physically like, trauma damage to it. You could have a lesion affecting that area. If you have, maybe a heart attack and you've got necrosis of that tissue, it could affect the way that those fibers are able to conduct. Hopefully that makes sense.
Yeah, that makes sense. And so the reason why there's an M-shaped R wave is because like if one side's blocked, then the other will go first and then the blocked one will go next.
Yes, exactly. Right? So remember we talked about the M shape as well in the P waves. That was for the atria. Similar thing will happen with the ventricles when there's a blockage, like an asymmetrical blockage.
Yeah, makes
sense. Yeah. So N-STEMI, you either have a depression or it's just kind of flat. Generally, it's a depression. This is going to indicate a partial thickness infarct, so not all the way through the muscle, or at least the tissue of the heart. STEMIs are going to be elevations, which is full thickness, so it goes across the entire tissue. Now, the main important thing is you can use which lead is affected to figure out exactly where the MI is, and then potentially implicate which artery has been blocked off, and which is causing that ischemia to happen. So this is if you need to take a screenshot of this, this is probably the most important sort of thing to be familiar with. It looks a bit messy, but I would encourage you to just sit down with this diagram, maybe draw it out yourself to know where everything is located, as well as figure out like, why is it that, for example, lead 3 is called an inferior lead? And you go back to those diagrams and think about where lead 3 is looking at. This diagram is just a good one to know. I think the major ones that they can ask are going to be your inferior lead. So remember, lead 2, lead 3, AVF are going to be inferior, but they can basically ask you about any of them. Now, we can use this to localize the coronary artery that's been affected. So this is the way I just remembered it. It is a bit odd. There's no real nice way to remember these things, but this is the way I did it. With the inferior leads, and again, look back at your diagrams of the coronary circulation, that's going to be more focusing on the right coronary artery. It's going to supply a lot of the inferior parts of the heart. The lateral leads are going to focus on the left circumflex artery. Again, think back to the anatomy. And then the anteroseptal, so in other words, this bit here and all of these leads here, if they're all elevated, you're thinking about a potential blockage of the left anterior descending artery. So these are just the 3 major ones to keep in mind. Okay, T waves, really straightforward. We know that there's a couple of dimensions to think about, but really you can just eyeball it. If you have tall T waves, we're thinking about some sort of initial ischemic event, whereas this one was after a bit of time, like the patient has come in and you can sort of trace these out, whereas maybe you might not be able to see tall T waves by the time a patient comes into the hospital. Inverted T waves happen in ischemia within 24 hours. Again, might not be possible if the patient doesn't notice that they're having it. And then the main thing is global elevations. So you want to make sure if you see a tall T wave, check if there's actually elevations in all the T waves everywhere. If that's the case, then you're not looking at an ischemic event. You're thinking more about hyperkalemia. And again, I would really encourage you to think about the physiology. Why is it that hyperkalemia leads to everywhere being tall tented or at least tall T waves? I've given the answer. That sucks. It's going to hyperexcite the tissue. So everywhere it's going to hyperexcite. So you want to check all of the leads everywhere. I'm not going to go over this section just because of time. These are all in your notes. I just put it in a sort of nice table for you to have a look at, so you can think about what does AFib look like, what does atrial flutter look like, what is atrial ectopic, ventricular ectopic, and ventricular fibrillation. Perhaps the most important one. If you see this, you know something's up. You definitely need to get it checked out. I'm going to have a look at the chat now. This is the end, by the way. If you need to leave, that's okay. I'm just having a look at the chat to see if there's any major questions. So I've gotten a couple. James, do you want me to answer these like afterwards rather than now? Just because I'm not sure if year ones have any classes going on.
I mean, if they're happy to stick around, feel free to answer them now.
Okay.
Yeah.
Okay, perfect. So we've got the first question as being, is the S wave deflected downwards because the Purkinje fibers depolarized from the, perfect. So you've kind of recognized that the Purkinje fibers, everything is going down. Purkinje fibers are kind of wrapping around the apex or like the bottom of the heart, going up through the ventricular tissue. So in effect, as it's depolarizing upwards, it's going in the opposite direction to where the positive electrode is looking at. Well done. So that's really good. I've got another one. Which bit needs to be longer to be positive? Oh, okay. Let me go back. So it needs to be the R wave. The R wave, remember the QRS complex? The Q is this, I've drawn it really badly, sorry about it, but the Q wave is this bottom bit going down here. The R wave is this one going up here, and then the S wave is going down again. So if the R wave, the top one, is going higher than what the S wave looks like, so in terms of just bare amplitude, not in terms of like, because the S wave is always going to be negative, but in terms of amplitude, if the R wave is higher, then we think it's positive. If you have a look here, the R wave is just like a little blip, right? It's just like going up a little bit. And then the S wave is quite deep compared to it. So that's going to be more of a negative. So hopefully that clarifies that a bit. Is second degree type 1 AV block irregularly irregular or regularly irregular? I like the way you're thinking. Let me go back to that slide. Where is it? Okay, so we're talking about type 1 AV blocks. So if you have a look at this one, it's actually going to be, I believe, correct me if I'm wrong, it's going to be more regular. So of course it's irregular rhythm because it's not following your normal sinus rhythm, but it's going to be regularly so just because the PR interval is longer, but it's consistently longer. So they're all going to be around the same identical getting in the way. So generally these will be regular. In actuality, all of these are going to be regular except for potentially your Mobitz type 1, just because that one actually, no, there's still a pattern to it. It kind of loops around, right? Still has a pattern to it. So technically all of these are going to be regularly irregular from what I'm understanding from their graphs. Okay. Hopefully the people who asked the questions are actually still here. Does anyone have any last questions before we stop? Because this is going to be the last time you see ECGs before your exams. No. Okay. Hopefully that helped. Enjoy the rest of your day and good luck for your exams.
Thank you.